Good afternoon, everyone. Thank you for joining us for this Big Data at Heart webinar. My name is Dwayne Schultes. I'm the Managing Director of Vital Transformation, and I'll be moderating the webinar this afternoon. Very much thank you for your participation today. So in this webinar today, we'll discuss how wearables have been incorporated into Big Data at Heart's research platforms, as well as highlight best practices and use cases developed in collaboration with the European Heart Network. And I'm extremely pleased to have an exceptional group of panelists with us today. Firstly, I'd like to introduce you to Professor Deepak Kotecha, who is the Professor of Cardiology and Cardiac Imaging at the University of Birmingham and University of Birmingham Hospitals. Deepak, pleasure to see you, sir. How are you today?
I'm good, thank you.
Thank you for being here. We also are pleased to have Professor Paul Dendale. Dr. Dendale is the chair of the Department of Cardiology at Jessa Hospital in Hasselt. Paul, always a pleasure, sir. How are you?
I'm fine, thank you, Johan. Glad to be here and to share our vision with the audience.
It's great to have you here. And as well, we're also joined by Martin Schoenberg, Dr. Martin Schoenberg, also from Jessa Hospital. Martin, how are you, sir?
Fine. I'm ready for my presentation, so looking forward to it.
So are we, Martin. Thanks a lot. So to get things started, Deepak, you have a presentation here. You're going to sort of set the scene and set the table for us and show us how things are being integrated into Big Data at Heart. Deepak, the floor is yours. Thank you very much.
Absolutely. Thank you, John. And again, thanks to everyone for joining us today. It's great to present to you today on some aspects of wearables. I'm going to set the scene a little bit about what we might expect in the future, in the near future, really. But also tell you a little bit about what Big Data at Heart have been doing in this sphere. So my disclosures are listed here. Big Data at Heart is funded by the EU and FPA Innovative Medicines Initiative, and I'll touch on that a little bit later. So what am I going to cover today? Well, you know, we all know that wearables are part of really our daily life, and they're becoming increasingly part of it. I'm going to have a little look at where wearables interact in the monitoring of the public and our patients. I'll use the example of heart failure, and then have a few thoughts about the innovations within the Big Data at Heart community. Martin's going to go into very nicely the sort of telemonitoring aspect of digital technology. So I'm going to stay out of that particular arena, but Martin will cover that in depth for you. So why do we need wearables? I guess there's always the question that's asked. You know, what potential can they add to us? You know, we have a lot of physiological markers. We have a lot of outcomes in clinical practice, both for trials and in our daily lives. Many of you will have done this with patients or been a patient and have this done to you. It's a 6-minute walk test. There's lots of varieties depending on whether it's cardiology or respiratory or whatnot. But effectively, these sorts of tests are used routinely in our hospitals up and down right across the world. But if, like me, most of your patients look like this, then of course that's a bit more tricky. And obviously we often have this scenario where we have a lot of time being spent by clinical staff, often multiple clinical staff, and perhaps the patient's status doesn't make them suitable to do the sort of tests that we want them to do at the time we want them to do them, which is, you know, when they come to see us in the hospital. So wearables really provide a huge prospect for lots of different monitoring. And I've just listed a few here from a paper from a couple of years ago. That hasn't really changed. We can still do all of this stuff. We've got more probably sensors now embedded in clothing than we've ever had before. And of course, you can get lots of different types of data and often multiple types of data at the same time. Of course, the huge value of wearables is in its dynamic nature, sorry, of these data. And that really is where they set themselves apart. So rather than just assessing the patient when they come into you at that particular time, of course, you've got a period of time that you're monitoring them, often weeks or months, maybe longer. And so it's data that's in their own home when they're active, doing what they normally do in their own lives. So looking at that heart failure example, you know, we're all familiar, I think, of the lots of different sensors that are available now. You can use these sorts of bands to look at intrathoracic fluid. You can even look at what's called seismograms from the heart to look at blood flow. There's lots of different types of sensor devices that include ECG and physical activity in patches and all sorts of things. We can look at weights through shoes even. And I think what I've sort of badged as hemodynamics is this huge broad array of things that are just coming onto the market, which are these things like, for example, smart mirrors, sensors that can look at your voice tone or your facial tone to look for medical properties. You would have seen earbuds that can do light sensing tests for photoplasmography. And then obviously that's all on the background of this connected smart home that we're all being exposed to, where things are communicating. You've got speakers and windows and mirrors and all sorts. And that really is not quite in the health sphere yet, but I think it will be in the very near future. If you thought you could get away from it all by going to the toilet, think again. These chaps have come up with a way of predicting heart failure by your toilet usage. So you're not even safe there. Of course, we have to be aware of the limitations of all of this stuff. We've gone really rapidly from very highly regulated medical devices to giving devices to patients. So, blood glucose monitors are a good example of that, but they are still very highly validated. We've gone into this consumer wearables sphere, which is great in the way that it can democratize this. It can give these devices to anybody who wants them at much cheaper cost. But of course, we have to bear in mind that that is accompanied by much less validation, with the algorithms potentially changing, this sort of black box approach, if you like. There are also lots of issues with data security. We're not going to go into those in detail today. I think everyone is aware in each of your countries what is happening. There's issues about excessive self-monitoring. You would have seen the headlines after the Apple Watch study. There are issues around inaccuracy. And also, of course, we have to remember that these devices are only as good as people are using them. And there's often quite a steep drop-off. So part of this is engaging with patients and the public to see really what they need and what they want and what they're willing to communicate and cooperate with in terms of medical devices. The other thing we have to remember is most of these devices, the new ones coming on the market, are commercially based. And you can see from the data on the left here that probably the people that want a smartwatch and can afford a smartwatch have probably already got them. Same for fitness bands. It's the rest of the wearables market that really is now projected to grow. And bear in mind that these devices are very much pitched to what people will pay. So the technology in them, these companies are running focus groups to see what people will pay, and that's what you get. So you have to remember that this is a consumer-directed expansion of these devices. But there's no doubt that they're coming into our clinics and people are wearing them, and potentially they can inform our healthcare. So coming back to BigData Heart, it's great to sort of present on behalf of the huge group of scientists. We have both academic partners as well as industry partners working together to really look at and try to improve how big data is used and developed and validated, particularly around atrial fibrillation, heart failure, and acute coronary syndromes. I'm only going to give you a really snippet of what's going on across the whole consortium. There's some fantastic work going on about how we phenotype patients with these conditions, how we can use electronic health and registry data right across Europe and elsewhere to really improve what we're doing, and how to get better at coding these things, how to be more transparent, and the ethics and the social license that underpins it. So I'm not going to go into any of that stuff, but take a look at the website and you can see the great things that are going on in the consortium. The only thing I will mention is something around wearables, and really we are interested here in developing again this idea of new physiological markers, perhaps even outcomes that we can use in future trials. We know that regulators are interested. Here is a trial that we've put in a wearable study to. It's called RATE-AF. I'm not going to go into this in detail. You can check the publication from late last year. But essentially, this was a randomized controlled trial where patients with atrial fibrillation and heart failure were randomized to either digoxin or beta blocker therapy. Again, I'm not going to go through all of the outcomes, but one of the headlines was that patients who were randomized to digoxin did tend to feel a lot better and a lot sooner on than those who were routinely given what we would consider standard of care, which is beta blockers in these patients. So we implanted wearables in these patients. not implanted, I should say, we gave wearables to these patients. I want to just point out the average age of these patients was 76. So these sorts of devices can actually be useful across the spectrum of age. And this is ongoing work, but what we did here is we used the consortium to its best efforts. So this is a combination of public and private academia and research scientists. We use passive monitoring in these patients, so using a wrist-based device connected to a smartphone, which also recorded a whole heap of sensors. And then on top of that, there was active monitoring by the patients. So they were accessing the European Society of Cardiology AF app. They were inputting regularly PPG sensors, so light sensors of their pulses. And that was put together in what's called the radar platform, which was developed again by another EU project by our colleagues at King's and UCL in London, and with the cooperation of the Hive, which is a tech company in the Netherlands. Again, as part of the BigData Heart consortium, these sorts of data can be put together and integrated for patient care. So just to give you a highlight here, these are two patients. They had exactly the same symptoms, so heart failure symptoms, class 2 MYHA, same 6-minute walk distance, and actually the same heart rate over 24 hours. But you can already start to see the differences between these patients when you use wearables over a 24-hour period. And in particular, you can see the difference that you get in physical activity and heart rate, particularly when you're doing physical activity. So there's a whole heap of information here. Of course, the question is how much that is valuable to clinical practice. If we look at across the spectrum of the patients, what we see is if you want to, for example, predict your MYHA class 5 months after taking these samples, actually wearables do reasonably well, and they do as well as what we would consider gold standard, doing 6-minute walk tests in patients, looking at their ECG and their heart rate. So these are certainly opportunities in the future for what we might do with wearables. If you allow me to future gaze for a minute, we've gone a long way from the integrated chip first coming up in the late 50s. All of us now pretty much have supercomputers in our back pockets. The question is where we go next. I think the key is integration. You know, we can walk through our homes, get scanned by our mirrors and the carpets that we walk on, connected to the devices that we wear in our phones and so on. So I think that's really the stage in the future that we're looking at. And that really is designed to predict patients before they get a disease. So in this case, early stage, pre-heart failure, if you like. I think the key bit here is that that information needs to be used to incentivize the person or the patient to seek healthcare. I think the days of ownership of data from the healthcare perspective are gone. This should be in the hands of our patients and those who are collecting this data for themselves. Of course, from our point of view, it can help with early diagnosis and also to monitor these patients, hopefully ending up with happy patients and happy healthcare staff. So I just want to end by saying, I think there are lots of challenges with wearables. I think we're in the midst of a tech revolution. We have to understand the limitations. We have to conquer some of the issues like privacy and transparency. But I think the key area is really turning this field not into a revolution in tech, but into then a revolution in how we can care for our patients. Thank you very much.
I say I want to get to Paul and Martin, obviously, but Deepak, there's one thing I'd like to bring up about your presentation. You mentioned that the average age of the folks that you did this wearable study with on the cardiovascular case study you just presented, they're 76 years old. For many of us working on certain aspects of this from the economic standpoint, the conventional wisdom is that when you get above 70, 80, people don't adapt and are not willing to wear these things. Did you see a high amount of dropouts, or is this not the case anymore? Are people just accepting these technologies and are able to use them regardless of their age?
Yeah, I think surprisingly not. I mean, you will always get the few, people who just won't get themselves involved in this sort of thing, and I think that's fine. That occurs no matter what age you are, really. I think it's surprising how quite a few of the patients afterwards said, "Do you have to take it away from us? We want to keep it." And I think the interesting thing is it'll come back to, I'm sure Martin will talk about, is this sort of health literacy and this idea that we can give patients, not just patients, but people, this sort of ownership of that information. So in our case, we found a lot of people saying, well, it was really helpful to know my step count. because actually then I could do better the next day and the next day. And, we had, even in this older age group, we had people doing a ridiculous number of steps, just to sort of better themselves, if you like. So I think all of those things are in play here. I don't think age itself is a barrier. A lot of people have, relatives and grandchildren who will happily, reconnect devices when they go awry. So I think that aspect is always difficult. But I think people are aware that this is something that, is becoming part of our lives. And I think people are very content with that. The data on smartphones is quite interesting. Smartphone usage has climbed in all age groups. And I think that gives you an idea, really, that people do find this potentially usable, even as they get a bit older.
That's great, Deepak. Thank you. I would like to present Martin now. Martin, you've done quite a robust and amazing study. I remember you said it was large and it came in at close to 600 pages. It was very impressive, an enormous amount of work. Obviously, we're not going to present all 600 pages of the case studies today, but if you could just go through some of the top line findings of your work, I think it'd be excellent, and it gives us a really good insight into what's coming and how we can potentially utilize this stuff. So Martin, floor is yours. Thank you very much.
Yes, thank you. Thank you for the kind introduction. So today I will focus only on heart failure. So what's the value of digital tools for heart failure patients? So first of all, I will start with what is heart failure. Heart failure is a chronic progressive condition in which the heart is unable to pump enough blood to the organs of the body. And therefore, actually, simply said, it is the heart can keep up with its own workload. And the typical symptoms are shortness of breath, edema of the ankles, and fatigue. But the problem is it's associated with a lot of hospitalizations and frequent rehospitalizations, which poses a significant burden on healthcare budgets, but also on the quality of life of patients. So both are very important, and telemonitoring could be an option for those to reduce that burden. Luckily, you could say there are several symptoms such as increased weight and changed blood pressure that may indicate a deterioration of the condition of the heart. So telemonitoring can help to remotely monitor patients and thereby prevent hospitalizations. But what is telemonitoring of heart failure? Patients get a weighting scale, a blood pressure device to measure important values like weight and blood pressure at home, and those measurements are automatically sent to the hospital. This allows that the treating physician and nurses can monitor these values and see if everything is okay. But when the values are not okay, they can also adjust the treatment and thereby prevent hospitalization. And that's one of the key goals of telemonitoring. You can also go even further. So in a study that we are doing currently in Yes Hospital and 2 other hospitals in the Netherlands, we are trying home hospitalization. Home hospitalization is actually a form of extensive telemonitoring, where we patients that would normally be hospitalized hospitalized for heart failure, we send them home with the right medication and with monitoring tools. And then a specialized nurse and cardiologist remotely monitor the incoming data, this blood pressure, weight, heart rate, physical activity, but also there's a daily visit of a heart failure nurse at the patient's home to assess clinical status. And in that way, we try to replace a hospitalization with just extensive telemonitoring at home. And why do we want to do that? Is because of that this approach has potentially numerous advantages, such as improved quality of life, because patients can stay at home. They don't have to come every 2 months to the hospital for 7 days. They can eat what they want, and they can just live their regular life. But also we believe that there will be reduced risk of falling, reduced risk of delirium, reduced risk of hospital-acquired infections, because the patient can stay in the familial environments. So that are the most important things why we try home hospitalization. So I think there's also one of the future innovations in telemonitoring is that we have different dosages of telemonitoring, simple devices for patients with less severe heart failure, and more extensive, more innovative devices for patients with severe heart failure or with an acute decompensation. So our review for the European Heart Network demonstrated that there were multiple studies in telemonitoring, and there were multiple studies that prove the effectiveness of telemonitoring. Like this study by Köhler in Germany demonstrated that telemonitoring is effective in reducing days out of the hospital and days lost by that. So it is effective, but still in the review we saw that there are other studies that could not prove that effectiveness. And there are multiple reasons why some studies failed to demonstrate effectiveness. One is they use different devices. Some devices are more difficult to use, and we saw that the patients were less adherent to them. And then if patients don't use the technology is not effective. But another one is also patient selection. We believe that, and we see in a lot of studies, that telemonitoring is especially effective in patients with severe heart failure. So just providing it to every heart failure patient is not effective, and especially it's not cost effective. And we see in a lot of European countries proving cost effectiveness is one of the key ways to get it implemented and to get reimbursements. So cost effectiveness, we have to think carefully about how we can implement digital health and telemonitoring in a cost effective way. But the second reason is that we still see that when we offer digital health interventions, a lot of patients don't want to use it or are not capable to use it. So I think it's very important to address things like data ownership, data security, and data privacy, because we see more and more patients that worry about who is going to see their data, who can sell my data, or things like that. So it's very important to be to educate patients and to give them all the information and to reassure them that the telemonitoring system is used to improve their care. Another one is that still we see that a lot of patients just don't own a smartphone or are not skilled enough to do telemonitoring. So also health literacy and digital skills and digital literacy are very important barriers for the use of telemonitoring. So I think it's very important. One of the lessons of the review was that it's very important to educate patients, educate them in how to use digital tools, but also make telemonitoring systems as easy to use as possible. And I think co-creation is very important in that. It's co-creation means that we are going to, when we develop a new telemonitoring tool, that we involve all stakeholders, so nurses, doctors, but also patients, so that we are sure that the tool is not only innovative and cool, but it's also easy to use and useful for patients. So I think that's very important to ensure that that all people can benefit from telemonitoring and not only the rich and the digital literates. So I think that's very important. To end, I think one other solution for telemonitoring for the patients that are less digitally skilled or don't own a smartphone is remote sensor monitoring, where we use implantable sensors or sensors that automatically measure blood pressure or pressures in the heart, and they also automatically transmit it to the hospital. So then there is no need for a patient interaction, and that could also make telemonitoring more easy. One example is the CardioMEMS device, which automatically measures pressures in the heart, and can be used to remotely and automatically monitor the condition of the heart, and then can alert physicians to maybe change treatment and prevent rehospitalization. So I think it's also something that Professor Kotecha already talked about. A lot of new passive monitoring is coming in the near future, or is already available, and will be very important for the implementation. So that was my short presentation. To end, if you want to see the whole review of 600 pages, you can go to the link below, and then you can learn everything there is about digital health and telemonitoring. Thanks for your attention.
Thank you very much, Martin. Again, a similar question I asked Deepak. When we look at the costs, do passive monitoring systems have a cost benefit compared to some of the other more expensive tool-based or toy-based systems where you actually have to wear something? I mean, is there a difference in these two things that you've been able to extrapolate?
Yeah, in heart failure, there are not yet a lot of like the CardioMEMS is not used regularly at this moment. It's something that's coming now. but those devices are very expensive. So it's not that that there was a clear cost benefit. One of the advantages is that when you give a patient a smartwatch, it's of a smartphone, it's not sure that are you going to use it, so it's not sure that it's effective. The advantage of an implantable is that you are sure that you get the data and that you can use the data. That's, I think, the most important difference.
That's great. Thank you, Martin. And our final presentation, we'd like to have Paul, you're obviously the head of the unit there. If you could just tell us a bit and give us some perspective about how you've been using or applying a lot of these technologies in the world of COVID and how these are potentially going to impact treatment going forward. Thank you, Paul. The floor is yours.
Thank you. Thank you, Johan. I will share my screen. So, yeah, how was cardiovascular disease care impacted by the COVID pandemic? First of all, I don't have anything to disclose, except that I work in the Yessa hospital, but that's a different thing. What was the impact? Well, the impact on cardiovascular disease treatment and follow-up was catastrophic. We had a decrease in hospitalization and emergency visits in Belgium and in Europe, and I suppose all over the world, of about 50%. And we checked that in our province. So we checked with the emergency services for unsuccessful reanimations or resuscitations at home. And so there was a parallel. There were less interventions for infarctions, but there were more deaths at home, and we also saw much larger heart attacks. So late presentations that were deadly, actually. So part of the deaths from COVID were people that did not go for medical care, and also a routine follow-up by cardiologists, GPs, etc., and also rehabilitation units, important in cardiovascular care. Following a rehabilitation program decreases your risk of recurrence by 30%. It was suddenly closed, nothing available. So what to do next was our question. And so what we did in our hospital, and we are a large non-university hospital where we already have been doing tele-monitoring for 10, 15 years now, in all forms, in studies and in routine care. So the most simple were the pacemakers and implantable defibrillators. They are already coming with some telemonitoring equipment. So the only thing you need in the hospital is dedicated nurses. So we have 4 telemonitoring nurses in our department and 3 heart failure nurses, all looking at telemonitoring data each day. So we have more than 1,000 patients with implantable devices that are followed from a distance. They are sort of a wearable, but an implanted wearable of high quality, of course. Heart failure has been touched upon by the previous 2 speakers. We had a program already with scales, blood pressure monitoring, activity monitoring at home. So we scaled it up, so to say, to include as many patients as possible. And as Martin already mentioned, we tried to send back patients after 1 or 2 days in the hospital instead of the classical 5 to 10 days for a heart failure patient. And we followed them up daily by these monitoring devices. Of course, all the normal consultations were replaced by routine phone or video conferences to triage and select patients that needed immediate follow-up. And rehabilitation, I will go into somewhat more detail. So we already had a program of telerehabilitation studies running, and this was a good moment to start using it in real life. So why telerehabilitation? We know that rehabilitation, as I said, decreases the risk of recurrent disease by 30%, and decrease the risk of mortality also by 25 to 30%. So it is imperative to participate. We reach in our hospital between 50 and 75%, but the median participation rate in Europe and the rest of the world is about 20 to 25%. So we are missing out a lot of patients, and many of them have as reasons transport, no time, whatever, things that could be helped by telerehabilitation. We also see that longer term follow-up is needed to really change lifestyles of patients, and that's things that can be offered by telerehabilitation. And COVID-19 gave us the opportunity to test that out. And just delaying rehabilitation, saying, okay, we'll wait until the peak has gone and then we will call you for rehabilitation, that's not an option, because we know that the results of rehabilitation in several studies are less if you start late, and also participation is lower and dropout is higher. So if you call a patient half a year after his heart attack to start rehabilitation, he won't come, or because he has started working again, or he doesn't feel sick anymore, or whatever. So you miss an opportunity to increase the effect of your intervention. And rehabilitation, it's more than exercise only. Of course, we know exercise is something that can be followed very easily from a distance with all kinds of wearables, accelerometers, smartwatches, polars, whatever. But there is more to rehabilitation. There is the patient assessment from a psychological, cardiological, exercise, diet point of view. That's something that can be done, of course, by video calling. Adapting treatment to the guideline-based dosages is something that needs to be done. And here again, monitoring at home will allow you to see if blood pressure is controlled sufficiently or not, if exercise is going the right way, if the weight is decreasing or not. Psychosocial management in our hospital was done by video calling. Nutrition counseling, important. Weight control in those that are overweight, which is the majority. Smoking cessation, and then of course exercise training. And so how did we do it? Well, it's actually a combination of things, tools we already had, some new tools we quickly developed or used. So simple phone consultations just for the first introduction to the team, for guidance by dietitian or psychologist or social worker, whatever. The rehabilitation instruction videos were available online, so patients could follow them at their own pace. Also some educational sections on our website. And we did also group training sessions, which strangely enough were followed even by the oldest patients. Following the group sessions was about 87 or 88 years old and doing active exercise in front of her TV. So it shows that if people are motivated to do it, you can use classically available. This was a simple kind of a social media tool we used for these sessions. So what did we learn? We did some reviews also in the different centers. First of all, if you were not prepared, COVID didn't teach you much. So many centers just stopped doing telerehabilitation, and well, a pity for the patients, but nothing happened in between. So those centers that already had some research or some primary systems running could jump on the running train and use it during this period. We saw that patients were willing to pay for rehabilitation. About 70% were very happy about the majority was very happy about the telerehabilitation, but about 70% said that also when COVID is over, they would like to have it also available, even in a mixed form of doing some exercise and sessions in the center and the rest at home. So EAPC, the European Association of Preventive Cardiology, made a call for action to try and implement this. You don't need very fancy tools to start a minimum of cardiac telerehabilitation for those patients that do not get anything. The future, in my view, is the more extensive monitoring and intervention. We are participating with the Hasselt University in the Coro prevention trial, which is a Horizons trial, where we develop at this moment a tool that is app-based, and that helps you to address education, smoking cessation, nutrition counseling, exercise, stress, smoking cessation, all that in a form of shared decision making with the team. So it's I think the future, measuring a lot of things semi-automatically by using apps and wearables, integrating them all in the program that is individualized for a certain patient, really personalized for this specific patient, instead of giving everybody the same intervention. So I think this is something that will prove to be the future. Of course, we'll have to prove it. So the trial will start in February. We will be randomizing 2,000 patients to this intervention or classical care, and see after a few years if we can really make this reality. So what after COVID-19? It's not over yet, as you all know. Well, the digital divide, we are at this moment trying to see if we can overcome this digital divide. Of course, this is something that will grow out of the population. Older people like my mother at 90 years old and her partner at 98 years old both use smartphones. So it is decreasing the digital divide, but we need to really make sure the devices are simple enough and educate the patients to use them as much as possible. We'll have to see about adherence, because there is some attrition in most apps you use. So that's an important one, the motivation of really continuing following the advice. Data ownership has been touched upon several times. I think data are the patient's possession and should be like that. Legal issues, the EU is working on that, of course. Interoperability is a difficult one, but with the medical device regulations, only big companies are now able to produce things for use in medical situations, and there this interoperability is not such a problem, I think. And then of course data privacy, and most important of all, reimbursement. No reimbursement will mean no use, except for a few early adopters as we are. So I think that cardiac rehabilitation and any form of digital cardiology, monitoring from a distance, is there to stay, is here at this moment. It's not the future, it is really now. Thank you.
Thank you very much, Paul. Very interesting presentation. I'd like to bring everyone in now. Thank you. Paul and Martin, just quickly, your work highlights that there's a lot of potential here for these beyond just basic home monitoring, which is what we've used these things for, Fitbits and things. But as Martin's data shows, there's often a problem of provability, or at least a lot of the applications are not yet validated with statistical evidence. What areas show the highest potential, and where should we be pushing to get that clinical evidence? Martin or Paul, whomever wants to go first. Which you think?
Well, maybe I will start first. So I think most data are available in heart failure, as Martin already mentioned. So there are big studies, and we learn from positive, from negative trials. Also in pacemaker follow-up from a distance, there are even big cost effectiveness trials. So I think these are ready for prime time. And as Martin said, the implantable monitorings, they have been proven to be effective, but only in small groups. So they probably need larger trials to really make sure. But I think the main thing now is implementation trials, really seeing if we have proof in 50, 100 or 1,000 people that choose to participate. What happens if you now involve everybody and say, okay, it's everybody, and that's what we are going to start in the next months. We will do an implementation trial. We will address everybody with heart failure and tell them, okay, we want you to follow this telemonitoring. Do you agree? And we will learn a lot from that, I think.
Martin, anything else you'd like to add?
You know, I agree with what Professor Dandal said, and I think indeed the implementation study is important part, because we need to know which patients are willing to use it, which patients are not willing to use it, because it's important for the reimbursement. But also I think we have to know how we have to change our organization, because I think it's a different way of working for nurses, but also for the hospital itself. Maybe we need less beds, but more computers and things like that. Is very important to know, because we need to change, and to make hospitals and the government change, we need implementation study and data, I think.
And Deepak, from the NHS's perspective, is reimbursement an issue in the UK, or is there generally an openness to this? Where are you at in the UK with regards to the big money question, as it is?
Very complicated. Is the short answer. So as you know, we have bureaucracies upon bureaucracies, and generally it works well for patients in the long run. And I think there's a move to making those processes much more simple. But as you know, we have an agency called NICE, which will look at the cost effectiveness. Obviously, to get to that point, you need really hefty data and cost effectiveness studies, and you have to produce quality. So it's challenging. I think just coming back to what Paul was mentioning, I think what you've got at the moment, this is particularly the case for consumer electronics, is that they're rapidly developing so quickly that it's very hard to understand how we could ever catch up, let alone get ahead of that game. And by the time those devices are out there, they're coming to your clinics, and I had a patient in my clinic that came with a wrist monitor. I won't use you've used it, but it was a wrist device. And actually that was very helpful because it showed me, he came with bradycardia. His GP had referred him with low heart rate all the time. He showed me his monthly reports, and there was very clear chronotropic competence. So you could see the heart rate was elevating quite normally with exercise. So I discharged him on the basis of his recording from his smartphone. So I think there are potentials there, but of course, these companies are under difficulty as well because we criticize them for changing their algorithms after the research studies are done. But on the other hand, of course, they're learning as well. And because of AI and an increase in artificial intelligence, we're learning what parts of those signals are more important. So it's a constantly evolving field. So I feel sorry for the agencies who are trying to monitor and police us with this, because I don't think it's going to be very satisfactory. So I think it comes back to what Paul was saying, is that we need to make this more democratic. And I think the issue is that we provide, that we accept these are patients' data, and we need education, I think, as well, as Martin mentioned, to know what to do with them.
And picking up on that, we do have a couple questions that have come in from the audience, one dealing specifically with the quality of apps and the quality of data, either. If folks out there have a question, please push on the Q&A button, submit your question, and we will circulate it to the panel. We're going to go through some of these now. As I mentioned, this is a question from Jonah Figueiredo. Thank you for your question, Jonah. Are those devices used for home monitoring certified as medical devices, including the apps used on tablets? This is usually a critical requirement. So what is the status of some of the tools we've been using in some of these studies? Are these certified for certain use? Or are we allowing them into medical practice without a clinical trial? Where are we at with that? Paul, you're nodding. I'll go to you first.
Yeah, okay. I was nodding because it's a very good question. It's indeed, you see a sort of a shakeout in the industry. Before, I've been working with small startup companies all the time in doing these innovative things. When I started doing telemonitoring in heart failure, was 15 years ago. It was really great to be able to send data automatically to a server. It was fantastic at that moment. This company doesn't exist anymore, and a few of the next ones don't exist either. And expect a very big shakeout now, because with the medical device regulation that is now starting in Europe, you really need to document extremely well what is done and every change in your system. I'm even wondering if it's going to be possible to continue doing this. But at this moment, the big companies, the Philipses, the Siemenses, the really the big players are coming in the field, and you see the small companies will go out, I'm afraid, because if you want to use it for any medical reasons, not the consumer, but medical reason, even if you claim that your wristband or whatever does something for your health, then you need to follow these rules, and they are so difficult. It's going to cost. In the core prevention trial, for example, it's costing several hundred of thousands of euros extra than we originally thought because of all the difficulties in documenting and the way things are produced. So it is something, it's a difficult period now, but I'm confident that in the end we will be having very trustworthy systems, because only the ones that are very well documented will be still available for medical use.
That's fine. And Martin, anything to add to that?
Yeah, only that if you want to do research now in digital health, it's very difficult, because indeed you cannot work anymore with startups. You need, if they have to follow the medical device regulation, so it makes everything a little bit more difficult. So it's now the learning phase, like Professor Dandala said. We see that it's now a lot of difficulties to start the studies, but it's something we will learn from, and that will indeed result in that the big players will survive. It's something we see already now.
Deepak, I got a question here for you. This is from Calm Carroll. Calm from IMI. Thank you for participating, Calm. It's always good to see you. The continuous data that wearables provide seem to be ideal to give a better picture of how individuals experience their conditions. However, given they are mostly consumer grade, as we were discussing, may not be medically certified. How do we square that circle? How do we balance that for medical decision making? Deepak, what do we need to do?
Yeah, I mean, so that gets posed all the time by everyone. I think, to be honest, though, you know, the horse has already left that particular part of the pen. I mean, the patients are using these. So whether we, you know, what we need to do is to understand what the limitations are at the basic level. But I don't think we can now say to patients who presented with this data, right, well, we don't believe it because you haven't done, and I think it's, you know, because you haven't done X, Y, and Z. I think it comes back to Paul's point. I think what we're going to see is some of the more innovative things will completely bypass the medical field, and they will go straight into consumer electronics. And we've seen that during COVID. There've been some really amazing technological advances, you know, particularly in clothing sensors that can measure all sorts of things. You know, they're just bypassing the medical field because it's too difficult. So we're going to end up with this information, whether we like it or not. I think what some of us have tried to do is to accept these devices are going to be flawed in some way, but maybe try to use the volume of information as its benefit. So in the case of the kind of risk type physical activity measurements, you know, what we found is that there's a lot of redundant data. In fact, the majority, you know, is going to be redundant data. And there are ways of using AI tools, neural networks, parsing, autoencoders to actually try to select features that are relevant in that. And in that way, you still have a lot of noise, obviously, but you're picking out more of a signal that might be useful. But I think that integration of technology is where this is heading to next. But I think coming back to that original question, you know, can we believe some of this stuff? You know, a lot of it, no. Some of it, yes. I think you have to take it on face value. But I think, you know, that example I gave you about that, you know, chronotropic thing, that's quite convincing to me. You know, I don't need to know really whether that device is 100% accurate. Even if it's 20% accurate, I'm still getting sufficient information from a clinical point of view to advise that patient. And importantly, that patient then didn't go on to have a 7-day Holter monitor and an echo and all sorts of things that they actually didn't need. You know, they're a young patient, they just need to get off and not be bothered about that.
So if bring your own device is becoming an inevitability, if it's just we're going to have to deal with it whether we want to or not, Deepak and Martin, I may come to you again. If bring your own device is a reality, what do we need to do then practically in your, like for your work, Martin, you're trying to prove this stuff is possible. What would we need to do to make that a reality in the current framework, or what needs to change?
Yeah, go ahead, Martin, you go first.
I think one of the most difficult things is that, yeah, there are different companies, they have different dashboards, different forms of data. So it's very difficult to have the same data. For example, in pacemakers, physical activity is measured in different ways by different companies. So you cannot compare, not always compare the same, it's not the same value. So that's one of the difficulties. It's also difficult to, in the end, we want electronic medical records that they are interoperable with, with the devices. But if you have to do that for 1,000 companies, it's very difficult. For 10 companies, it's even already difficult. So I think that's, from a practical point, it's very difficult to make that happen. and to really for the interpretation of the data. I think that are the most important things. And then you have also the legal and the medical device regulation thing that we already talked about, because it's actually not possible to really use in a systematic way to use non-medical devices, so for clinical diagnosis or clinical follow-up. So I think that's another problem that has to change in order to make this part of the future.
But theoretically, would it be cheaper? I mean, would it be more cost effective? Paul, what do you think?
Yeah, sure. Of course, we do it already now. In the past, we gave the patient a pedometer to measure their steps, and now we say, okay, put your smartphone in your pocket, and we will see what data come out. And as Deepak said, the quality of the data sometimes are not reliable. But for example, just if you want to make your patient move more in rehabilitation, then the exact number of steps is not so important. We know if there is an increase, if the measurement is always more or less the same, then it's already good enough. On the other hand, if, for example, you have a device that measures blood pressure and it's always 20 millimeters mercury off, then it's not useful. So it depends on what you measure. If the data, if the precision of the measuring device is important, but it gives us, as Deepak said, a lot of data we didn't have before. Like, for example, we measured blood pressure in the office once, twice, 3 times, but the patient comes in with 250 blood pressure measurements. That's much more reliable. So I think it will give us data that are much more useful, and then using artificial intelligence to look for patterns in these measurements is what I think is what is coming very soon.
And Deepak, any other comments you'd like to make?
No, I think we've covered everything. I think the key thing will be to continue to educate people. You know, the ESC and other big agencies are trying to do that, you know, with their digital health committees. I think that's a push around the world. You know, we don't just need to educate clinicians, but also the public about what these things are. I think, you know, I hesitate to say more research, but more focused research, particularly, you know, where these sorts of devices, the consumer devices, are entering our medical field. It is helpful, I think, to see, you know, what exactly are the elements of precision that Paul was mentioning. You know, what do you need to know? So in AF, you know, you've got these devices telling you that, you know, you've got an AF alert. What does that actually mean? So those sorts of studies, I think, are important, and they need to be done by us as academics and healthcare professionals, separate from those companies, so that we can get some idea of how we can interpret that and use it in clinical practice.
And I've got a question here from Maureen Cronin. Hello, Maureen. Maureen's one of the project leads. As we were discussing, gentlemen, before we started, you are all evangelists. You are all on the front end of the curve for this technology, but unfortunately, many of your colleagues are not. And Maureen's question relates directly to that. Do you plan on looking at the effects and how best to change the ecosystem, I think as far as the paradigm, the mentality of nurses, patients, payers, et cetera, to support these changes in healthcare in your studies? How do we move the bar to get people to buy in, your colleagues to buy in, the payers to buy in? Deepak, you mentioned the bureaucracy. How do we move that? Deepak, I'll start with you. How do we deal with this practically to try and change minds?
I think they're doing so already, and I'm kind of I'm very enlightened by discussions we've had with FDA and even others. I think they are seeing this as a necessary move. I think the FDA, in particular, the device breakthrough program, is really interesting. Both EMA and FDA and MHRA and others have really taken on digital health and have programs. I think there's Darwin in the EU and other programs similar in America. So I think that is coming. I think one area that possibly we often neglect, and we talk about age, but I think the bigger issue is around diversity in terms of the ethnicities of what we're including. I think also, rather than age, you know, we need to look at the payment for these. You know, we've pushed all this on to people, and of course we're going to disadvantage those who are already disadvantaged in our societies. So, you know, in our study, we gave people a mobile phone, a smartphone, and a wrist device. But of course, in reality, when you're putting those in clinical practice, you're going to say, as Paul mentioned, you know, can you use your own phone? Because we're not going to be able to afford on the health service to give you a phone each. So I think we've got to remember those aspects as well when we move forward.
That's fine. And Martin, from your perspective, you're a younger emerging practitioner. Do you see differences in the willingness to use these tools at your age as opposed to some of the people you may have not necessarily disagreed with? I wouldn't say that, of course, but maybe have had issues with in trying to implement some of these changes.
I think most of the general practitioners, mainly we speak with, are willing to use it regarding the age. I think the younger ones are more tech savvy and therefore maybe more ready to, are willing to use it because it costs them less time to use it than some of the older physicians. But I think in general, most of the physicians I speak about it are very interested, but they're just like, they're always give me the feeling, the technology is not ready yet, but when it's ready, then we want to use it. But I think we try to demonstrate today that the technology is ready and that now the organization has to change. So I think there is sometimes a little bit of gap, but most of the time, I don't see a real age difference in acceptance of digital health and when I propose it to other physicians.
And Paul, as you're the head of the department, I mean, you can obviously force changes. Do you see people being very accepting, or I'm using a very liberal definition here of force?
Forcing, unfortunately, won't work. No, I see your point, and I think that the way things will spread is from large hospitals towards smaller hospitals, towards primary physicians, towards nurses. For example, heart failure. We have 3 heart failure nurses in the hospital. A general practitioner doesn't have heart failure nurses for himself. So what we do is use technology as a bridge between hospital and the primary care physician. So we really work together on this patient with messages from one to the other. And I think that's the way the knowledge and the use will be spreading. I see, for example, we start in our hospital. We have a network of hospitals. Now we have more and more this implementation in the network hospitals. You can even have a central telemonitoring unit for different hospitals and different general practitioner services together. So I think that's the way to go forward, that the ones that are convinced and have the devices and also the money, of course, start these projects and then involve others so that it becomes just a natural way of doing your medical job.
I think there's one other, if I come back, because there's one other thing there that's important. I think this opens up the sphere of clinical research as well to those who wouldn't normally be involved. And I think, we've just started a remote clinical trial, completely remote clinical trial nationwide in the UK, in England, and we use devices to just, enroll patients and to communicate with them, to do their patient-reported outcomes and so on. So they don't have to attend a hospital or a healthcare center at all during this randomized trial. And I think there's a real opportunity for this and other things to really bring patients in who would not normally have ever thought about contributing to health. And these patients in particular are never seen in hospitals, so you would never recruit them into a usual clinical trial. So I think there's lots of avenues here that are important. And I think it's about finding the right areas that we can really push on to sort of link up some of our health systems.
Ladies and gentlemen, we are almost out of time. Hard to believe, an hour has gone very, very quickly. We've only got a minute left. I do have one final question I'd like to ask all 3 of you. And it's really, if we had the opportunity to get the low-hanging fruit, to really go quickly here and make one recommendation, if you had the power to sort of implement one change tomorrow to see this stuff actually workable, reimbursed and everything, what one change, if you could wave a wand, would you like? Martin, what would you like to see done first, if you could?
I think the first thing is educate young aspiring doctors and nurses about digital health, artificial intelligence, and how to use data, the incoming data, to make diagnosis and give advice to patients. So I think that would be my go-to goal.
Thank you. Paul, from your perspective, what would be the one recommendation that, if you could, in your department, just to make happen immediately? What would you like to see happen?
Well, focus on heart failure. These are the patients that are coming back and back and back. It's a growing population, and we have the best data for heart failure to keep them out of the hospital and work towards home hospitalization. So I would go for that group and to reimburse some parts of the follow-up.
Thank you. And Deepak, final word to you. What would you like to see, if you could, what would you like to make happen to make this viable?
I think we just have to be much better, all of us, at co-creation with patients and the public. I think that is how you make this work, is by taking what the public and patients want and designing services around that. I think the only way we can do that is much more open and constructive dialogue, and bringing the patients on in that journey, particularly in clinical research, I think is vital.
Gentlemen, thank you very much. It's been an exceptionally enjoyable webinar and great discussion. Thank you for our audience for your participation. We are out of time. And with that, I wish everyone a good afternoon. Have a good day, everyone. Bye-bye.
All right.